I'm really delighted to have this conversation with Dr. Sandro Galea. And we're going to talk about not just health, but what makes health. This is one of a series of conversations we're having about health with leaders from around the US and around the world, looking at the challenges we face and the opportunities we have for progress. Dr. Galea is Dean of the School of Public Health at the Washington University in St. Louis. He's a population health scientist, a physician, an author, a speaker. He is the editor-in-chief of JAMA Health Forum and an elected member of the National Academy of Medicine. Sandro, thanks so much for joining. We have so much we can talk about. Why don't we start with what is somewhat top of mind, the Ebola epidemic that's happening right now in the Democratic Republic of Congo, where we're seeing the confluence of factors, what could become the biggest Ebola epidemic in history at a time when many of the structures of public health have fractured and a lot of the trust that's needed to control outbreaks has fractured. We're seeing a weakened US CDC, a weakened WHO, and an outbreak happening in one of the most challenging parts of the world where there's security challenges and conflict and limited health services. What's your take on how we got here and how do we get out of this mess?
Yeah, first of all, Tom, that's good talking to you. Thanks for having this conversation. The Ebola outbreak, it feels like the paradigmatic example of what I think many of us have been worried about in the moment. We have been in the past year and a half seeing this period of extraordinary dismantling of structures that were taking for granted in public health, national structures, global structures, as you mentioned. And time has been passing, and it's almost like this happens while nothing's really happening. I think many of us have been aware, as I'm sure, I know you've been aware in your writing, that if a tragedy happens, we're going to be deeply unprepared for it. And Ebola feels like that. And it is, there have been other Ebola outbreaks. We have been, as a country and as a world, better able to contain them. So I feel like this is a prime example of how the infrastructure of protection that public health affords is all of a sudden not there. And we are seeing that. And of course, what we're seeing in this country is alarm about that. And to be completely frank, some of that alarm is a little bit cynical because it's linked to the FIFA World Cup. The alarm should obviously be about the health of people who are in the center of this epidemic and our collective health globally in terms of the potential spread of Ebola. So it is a tragic moment that is reminding us of what we have to lose when we dismantle public health structures. And I think I was hoping, like many of us, that we're going to make it through this moment until we get to a place where we start rebuilding without such tragedies, but that's almost too much to hope for.
Well, let's go from far away to close to home. Tell us about your new gig there. You're in Missouri.
St. Louis. Yeah.
And I think are you the founding dean of that school?
I am. Yeah. I came here specifically for that. So I had been, as Tom, I spent 10 years in New York as at Columbia, then I spent 10 years as a dean at the Boston University School of Public Health. And this Washington University invited me to consider the position of being the founding dean to start a new school of public health. And Washington University is one of these sort of leading American universities with an extraordinary program in medicine, which has been around for many decades as a leader in biomedicine, but has never had public health as a partner to medicine. And when I looked at the possibilities here, it really struck me that there's enormous possibility within Washington University to build a school of public health as a partner school of medicine. But more importantly, there's this possibility to build great research-based public health in the middle of the country. When you look at where we are, St. Louis is right in the middle of the country. And you draw a circle around St. Louis for 400-mile radius. There are no real leading research-based schools of public health. And that circle in the middle of the country is almost a quarter of the contiguous landmass of the US. And I think if we subscribe to the idea, and I do, that academic institutions serve a function of generating ideas, generating the science that then is translated and taken to action by many people, the fact that we don't have those ideas coming from the middle of the country seems like a shortfall. And the opportunity opened up at an interesting time in my life. I'd been dean for a while, and I thought, wouldn't it be interesting to be part of an effort to try to shift the conversation in the middle of the country? And here I am. Now, of course, I signed on to do this job really in March of 24, but I started doing this in January 25. And as you know,
Hmm.
the whole world of public health changed in January 20th of 2025. So I found myself building the scope of public health in the middle of these extraordinary shifts in public health and these challenges to public health. So it has been a journey. I was expecting it to be a challenging period. I'm not sure I was expecting it to be anywhere near this challenging. But at the same time, we now have built a school. We have great faculty, staff, students. We've graduated our first class, and I see tendrils of hope. So simultaneously, while saying it's been an extraordinarily challenging journey, it's also been a very hopeful one because every day I feel like I have the privilege of actually building something, even though it's a time of challenge.
Great, great. Well, to tie those two things together, uh, Ebola in DRC and the School of Public Health in St. Louis, what has surprised you, not about the difficulty of the context since January of 2025, but about what you're learning and observing and
Mm.
seeing and discussing with colleagues and students and faculty and community members in St. Louis?
We talk a lot about academically about the biases that we bring with us, and I think there's quite a bit of awareness now around the fact that we have priors and we see the world through particular lenses, and we all live in particular ideological bubbles. But despite how aware we are of it, it's really hard to shake it. And being in the middle of the country, I am surrounded by a different foundational set of conversations than I was in being on the East Coast. And it's not that one is better, one is worse. They're just different root conversations. And I feel like if we are to truly move public health to being for the health of all, we actually need to learn those conversations. All, no one of us is ever going to embody all those conversations, but we need to be able to have those conversations from across the country. And I thought that would be the case, but like many things, you think about something until you intellectualize it, and then you live it. And living it has met that promise. Like I am able to see things differently than I was able to when I was in my previous position. So my hope is
Can
that,
you give us one example of that? What do you see differently?
well, I think, for example, issues of faith, which are, data showed us very clearly, like in the coasts and the large cities in the coasts are, understood, but largely a matter of abstraction in many academic circles. They are not in large parts of the country, and it makes it much more concrete to be able to understand that people are weighing things differently, weighing decisions differently, based on their beliefs and their religious beliefs, and that is. It's one thing to intellectualize it. It's another thing to realize that this is the character of the country, that you're dealing with half the population who sees things differently than the other half. And I think this has been a thread in some of my writing. This has been a thread in my book that's coming out in the fall, that we need to genuinely make an effort to understand people who see the world differently than one another. And I contend, I actually don't know how you feel about this, Tom, that public health in this country has had a hard time with this. I think we've had a hard time with this. I think there has been a concentration of one particular perspective, and I think that has hurt us.
I agree with that. Tell me, do you think it's a potentially winnable battle to discuss with folks throughout Missouri, not just St. Louis, why they should care about Ebola in DRC?
Oh, absolutely, absolutely. I have yet to meet anybody who doesn't care about the health of their children. Doesn't matter what people's partisan stripes are, what people's ideological stripes are. When you reduce it to this is about the health of your children, one has a very easy starting point for common ground and conversation. And so I think caring about Ebola in DRC. Now, some of that might come from caring about you and the risks to you, but I also think that, and I've written a little bit about this as well, my assumption is, and I have yet to be shaken from this, most people, most of the time, are good people. Most people, most of the time, want the good for other people. And it's a matter of us finding the thread that can bring people together. So I think sometimes in a highly polarized, combative public conversation, it's easy to forget that. But I think it's the extremes that are leading that conversation. And at the same time, as I'm saying, it's been very helpful for me to be in the middle of the country to see the world differently. It's also very helpful for me to be in the middle of the country to see that the our shared humanity, being middle of the country, being the coast, the east coast, west coast, is the predominant characteristic that people have in common. We're fundamentally people care about our children's health, care about the health of our loved ones, and we in public health need to make sure that we find that thread.
I think one of the things that's made this particularly hard is COVID and the hangover from COVID, and the fact that we've never really come to terms with what went wrong, what went right. Um, a lot of the discussion of this is so polarized that it's difficult to kind of say, let's look and take the look at the good and the bad, what went right, what went wrong, what did we learn, what did we do differently. I don't see a whole lot of interest in doing that. I see on the one hand really a lack of interest in thinking about COVID. It's like, that was really unpleasant, I don't want to think about it again. And on the other hand, a lot of oversimplifications, including in academia, where my own view is that if you're going to analyze what went wrong and right with COVID, you have to do it by time frame. There was a time when we had no vaccines, no treatment, and very little knowledge about how it spread and how to treat it. And emergency departments were overwhelmed and lots of people were dying. That was one moment where there was one set of realistic, reasonable things to do. There was another moment when we got this remarkable news that the vaccine seemed to be not just protective, but to protect others. If you remember the first month or two, when the results came back, they looked just phenomenal, that people not only didn't get sick, didn't go to the hospital, but didn't infect others. And then as we learned more, we saw, oh, actually that immunity wanes within a couple of months. So the argument for mandating vaccine, in my view, got way weaker once it was clear that it's going to protect you, but not do much for people around you. And then the virus is changing. So early on, we pushed hard on contact tracing, and I don't think that was wrong. But then when the Omicron wave came, it's impossible to do contact tracing when it's spreading everywhere. So I think if we're going to really come to terms with what we did wrong, what we did right, and more importantly, what we should do differently now, we have to get granular about the period in time of our response, the period in time of the virus's evolution, and the evolution of our knowledge about it.
Yeah, I don't think there's anything that you said that I disagree with. I mean, I do think that there have been some efforts to at least grapple with some of the conceptual challenges that happened in COVID. I mean, in my book, Within Reason, that came out in 2023, I tried to at least tackle some of what I saw as the philosophical challenges that the field had to deal with. There have been a couple of other books that have done the same thing. What you're describing is a much more detailed forensic exercise that hasn't been done yet. I mean, the post-war, the COVID Commission report, that wasn't a commission, did some of that. But I agree with you that we should be doing that. I also agree there's COVID fatigue and people would rather not think about it. But just to talk about COVID more broadly, number one is, before we even talk about what public health may or may not have done wrong during COVID, we should acknowledge that a lot of the challenges public health faced during COVID came from rather cynical partisan jockeying that public health got itself caught up in. I mean, COVID emerged in the run-up to a federal election. It was almost inevitable that there were going to be these strong forces that push public health in one way or another. So I just want to be very clear that I think there were these external forces that were really hard for public health to deal with. So having said that and putting that aside, we can discuss some of the conceptual challenges that public health struggled with. Public health struggled with communicating with certitude, and some of it being false certitude. Public health struggled with communicating in a way that allowed itself space to then shift as the data shift, to go to the Daniel Patrick Moynihan, aphorism. When the data shift, I change my mind. And there's nothing wrong with that, but we struggled with communicating that. There were many reasons for that. There were a lot of pressures. Social media was new. We didn't quite know how to deal with the false impression of certitude of social media. I think public health struggled with trade-offs. Public health struggled with the need for contextualizing trade-offs. That the trade-offs that might be acceptable in Florida were different than trade-offs that might be acceptable in Massachusetts. This is a big country. I mean, it's fundamentally a continent. And if you compare the size of the US to the size of Europe, roughly the same, there were dramatically different approaches in Europe. And in the US, we struggled with trying to find one size fits all. So I think there are many reasons for what happened during COVID. And I think we'd benefit actually from a careful forensic accounting. We'd learn from it. Whether we're ready for that, because there is this like emotional reaction. It's like, you mentioned COVID. Do you really want to mention COVID? I'm not sure we're ready for that in 2026.
I will say that one of the things that my group, Resolve to Save Lives, promoted was the use of a risk alert level framework where basically you empower communities and people to know how hard it's raining COVID outside. Just as we empower people, we empower people with things like how much pollen there is, and whether it's wildfire season, and whether it's a high ozone day. And then you can make a decision for yourself. You decide what you want to do to stay safe. And I think exactly as you say, communities can decide, hey, we're going to keep our senior centers safe, or we're going to open our bars. It's really something that's about empowering people and communities. But one of the things that I think comes out of this is the question of how to regain trust, because it's clear that rightly or wrongly, and certainly with some justification, for many Americans, COVID broke their trust in a lot of things, in public health and healthcare, in the news. And I think we're still dealing with the hangover of that. And if you agree with that, then the next question is, what are some practical ways to go about rebuilding that trust?
Yeah, no, I agree with that. Perhaps I'll start with how I think we don't go about rebuilding trust. I think we don't go about rebuilding trust by saying, trust me. I mean, anytime anybody says, trust me, you probably shouldn't trust them. I think we go about rebuilding trust by doing our work and doing it better and being clear about the fact that we are actually doing it well right. I've written a little bit about this. I think we need to listen. I think we need to listen better. I think we need to make sure that our science is impeccable and clearly marked as different from our values. I think we need to be very clear about making sure that we care about health for all people, that nobody's left behind. And I think we need to tell the story of our successes, tell the stories of our failures. And I think part of that is actually having the conversations within public health about what went wrong with an openness of mind and spirit. I think in much the same way as the public might not be ready for a COVID conversation, I'm not sure the field is ready, because I think there remain enormous sensitivities. And I don't subscribe to that hesitation. I have been, I've written about this. I've tried to surface these issues, and because I think it comes from a place of respect and affection for a field to be able to challenge some of its precepts and how it thinks in a way that builds up rather than tears down. I think there's a lot of space for that in public health right now, and I think we should inhabit that space.
I think on COVID, it's hard to know even where to start, because there's so much controversy and so much of a difference of opinion. And I think, as you say, a lot of rebuilding trust is doing our jobs right, addressing people's concerns, communicating effectively, and also sharing the lessons of what we've learned and what we know. This ties into the Make America Healthy Again movement. And I think what you've seen is kind of the combination of really sincere, legitimate concerns. What's in our food? Who put it there? How can we find out? Who's profiting from it? And frankly, a misinformation industry that is profiting from selling stuff on the internet, from selling subscriptions, from suing companies. And so you have this complex combination that often starts with very valid insights, and then sometimes, not always, but sometimes veers off into directions that are um, not likely to meet the goals of the movement. So, what do you think about that, and what do you see from where you sit in Missouri now on it?
I mean, how can you not subscribe to a movement that's committed to making America healthy again? I mean, the idea behind the movement, as you said, is entirely legitimate, and in fact, it's congruent with what many of us in public health have been talking about for years. I mean, if you read the MAHA report, the first MAHA report, right, the lead up to it is a pretty standard public health argument that we have been investing more on health. We get less out of it. You compare it with other high income countries and say something's wrong. I mean, that is canonical thinking in public health. So I feel like the motivations of the MAHA report come from the right place. And there are many elements that have motivated the MAHA movement, which we should recognize, of course, is not a single movement. I mean, it is really multiple different movements that coalesced under one for a particular political moment. But the notions of having safer, healthier food, the notion of being cautious and prudent about how we move to drugs, how much we medicalize certain things. I mean, these are valid ideas which have a real place in thoughtful conversation. Of course, what happened is that ended up getting caught up in a particular moment when movements were beginning to exist for their own sake, and then it accumulated all sorts of other ideas around the MAHA movement, many of them sort of running against decades, centuries of scientific consensus and clear evidence of life-saving approaches like vaccinations, and that's really problematic. So how do we deal with that? I think we engage. I think we have the conversation. I think we listen, and we try to create forums where people who are part of the MAHA movement, not part of the MAHA movement, can be part of conversation. And I mean, when you look at the data, despite the visibility of the MAHA movement, I mean, things like vaccination rates, we talk a lot about how vaccination rates have changed, but they haven't changed that much, right? It's sort of I mean, there remains a strain of logic and reason in the country. And I think it's important to emphasize that.
Let's talk about personal health for a minute. And I want to thank you for a very positive review of my book, The Formula for Better Health, that you
I really enjoyed the
wrote
book.
in the Lancet. And you in the midst of calling it a message of hope, which I appreciated, though I also hope it's a message of how to get stuff done. You made I think, very valid critique that I applied the formula, which is see, believe, create. I think your words was somewhat less convincingly to personal health. And that was, I think, accurate foreshadowing of how it's been received, because I put a lot of work into the final chapter, and I basically applied epidemiologic reasoning to all of personal health to come up with, like, from an epidemiologist perspective, what really makes a difference in personal health. And it came down to 6 major factors, and what people have said is, like, we know that, but like, we know that versus we do that is the big difference between how healthy we are and how healthy we could be. And the MAHA movement is trying to get to some of that, and it's about getting enough sleep, getting enough exercise, eating healthy, avoiding toxins, and the fundamental things of controlling blood pressure and cholesterol, which are so important. I feel like we lose track of the scale of importance. Someone will say, well, I'm going to take this action for my health. And I might think, well, that's really, not bad. But if your blood pressure is still 150 over 100, the benefit you're getting from that action may be 1/10,000th the benefit you get from lowering your blood pressure by another 20 or 30 points.
Well, one of the things that I think has been a hallmark of your leadership in public health, Tom, is you've always been outstanding at looking at what is going to matter most to the health of populations and then devising programs to affect populations on those levels. I mean, you did that certainly in your work around TB, you did it in New York, you did it through the CDC. And I think that's an extraordinarily effective tool. The question is, does that then apply to the individual? Does that apply when you tell me, well, actually, here's the one thing? I think the challenge with that is it is the ultimate rationalist approach. But when it comes to me, the individual, now I am weighing all sorts of other things that are very hard to understand from the outside because I have many other things that I value. And on the aggregate, I think that's achievable. And I mean, you've shown it's achievable. You don't need me to tell you, you've shown it's achievable in multiple scales, multiple contexts, to your extraordinary credit. But when it comes to the individual, it's much harder to predict which individual is going to take that up. I mean, you and I are both epidemiologists. As far as I'm concerned, the most important foundational insight of population health science is that you can predict populations, and we are horrible at predicting individuals. And of course, the reason is because individuals are influenced by, I'm going to get technical for a second, innumerable confounders that vary individual to individual. So I suppose, when I said less convincingly, it's I fear it's not because I had a better answer, but because I'm not sure that telling me these are the three things means that that's going to resonate with me. At a population level, it's probably going to resonate with many people. I just don't know that or I know whether it's going to affect me. So I think we have a long way to go there. And I'm not despairing about that. Like, I actually think that the act of population intervention saves so many lives. I mean, you make this point in your book. I mean, I've seen you do it in your career. I think that's okay. I mean, there is a different approach to take with individuals. I'm not sure what it is. I'm just not sure that the population to individual mapping is that simple.
I think it relates to something we see sometimes. There are some medical commentators who I think really highly of, and they're really accurate on the clinical stuff. But when they say, well, if a patient wants their blood pressure to be in the 130s or 140s, it's probably not going to hurt them. In a sense, they're right. And yet, in a sense, oh my goodness, if everybody does that, we're going to have an extra 100,000 heart attacks this year that are preventable.
Well, absolutely. The issue is if everybody does that. The problem is at the individual level. I know, know is that, I mean it instinctively, right? I know that there are many people like me with higher blood pressure than people like you with lower blood pressure, and you may still get sick and I may not get sick. That's the wrinkle at the individual level. Now, as you say, even as you said that, you are going from the individual to the population. You said if hundreds of thousands of people do that, then we're in trouble. But getting hundreds of thousands of people to do something is different than getting an individual to do something.
I think it's a reflection of Jeffrey Rose's prevention paradox.
This is exactly what's in my mind as we're speaking. Of course.
Small changes across large populations give you enormous challenges, enormous changes across the population, and that is the enormous challenge of public health. That the benefit we are inevitably going to be the underdog because there will be concentrated opposition, whether it's individual habit or the tobacco industry, to specific actions, the benefits of which are kind of spread out across both more people and longer time horizons. So we're getting to the end of our time. I want you to bring us home on a message of hope, despite the challenges that we've been talking about beyond what you've said already. What gives you hope looking at the next year, the next 5 years, the next generations? What should we leave those listening to this with?
I think what gives me hope fundamentally is history. We may have challenges in the moment, and we may feel like this year is a step backwards in terms of the structures we're trying to build to create a healthy population. But any objective observer will realize that this year is better than 10 years ago, which was better than 10 years ago. History teaches us that we're heading in a better direction. Hans Rosling, who was a population health scientist, who's now passed, right, used to say, the world's a terrible place. The world needs to get much better. And the world is a much better place than it used to be. And I think all those things are true. So we are part of an inexorable march to better. And that should give all of us hope.
I would agree almost. And I cite Hans Rosling as pointing out that things can be bad and better. And these are very hard ideas to keep in our mind together. But I don't think it's inexorable. And I discussed this actually in the epilogue to the book, where I made that point to Sir John Crofton, one of my mentors. And he remembered being part of the British Army. He was a doctor, and he retreated across Africa, across Europe, as they lost battle after battle. And he said, you know, if the US hadn't gotten into World War II when it did, Hitler would have won. So progress is not possible, but progress is not inevitable, but progress is absolutely possible if we combine forces, if we are strategic, if we listen and build coalitions. And I think that's not just, if it were inevitable, we wouldn't have any work to do. It's not inevitable, but it's definitely possible. So let's go back to work making for a healthier world. Thank you so much, Sandro. It's wonderful to speak with you.
Tom, likewise, really a pleasure.